All right. Welcome and good evening, everyone. My name is Colin Rigney. I'm one of the founders of AMSKU. And on behalf of the organization, I just want to thank everyone for making the time to come with us to be here tonight. This is part of our monthly webinar series where at AMSKU, where our mission is to just elevate the standard of healthcare and doing our little part here in the MSK side of the world. And we're lucky and thankful to have a good friend and a colleague come on tonight and discuss MSK Ultrasound as a catalyst for strong orthobiologic practice. We'll get into that intro here in a sec. I'm Colin. Ryan Martin is the co-founder. You're looking at the slide here. We're both physical therapists by background, extensive background in integrating practices, physical therapy and medicine, non-surgical sports medicine, and bridging the gaps between the disciplines with that skill set. And so Ryan is an active partner in AMSKU as well as modern physical therapy here in the Valley, where we have 7 locations, and we're really just again focused on just elevating the standards. So I want to just spend a second and talk a little bit about Ariana. We can skip past me. This is an individual who you're going to hear from, and you'll get to hear more in depth her background, her story. But she's a leader in the field. She's somebody who is at the tip of the spear when it comes to the application of bridging that gap between what the standard of care is and not operative management for MSK conditions. And as an orthopedic surgeon, she's really done an extensive kind of build in her skill set to not only perform these things, but educate. She's a top line educator. She's sought after not only in this country, but internationally for her skills and her speaking acumen. And we're just really thankful to have her on tonight. And really we don't take her time lightly. Again, good friends. And, we just have so much respect for her. Ariana, I'll give you the floor right now and you can talk a little bit about your intro story and get into the meat of the evening.
My name is Ariana DeMers. I am an orthopedic surgeon by training, as well as an ultrasonographer and an expert in regenerative and orthobiologic medicine. And so I wanted to thank you guys so much. This is great. As you know, ultrasound is one of my passions. So I think what we'll do is we'll just dive right in to kind of I made a couple of slides for you guys, so I'll share those. We'll just, if you'll bear with me, hopefully we can make this happen, and we'll get going. And so we're going to talk a little bit about the right tool, the right treatment at the right time. And as we said, I am a board certified fellowship trained sports medicine orthopedic surgeon. And I've really kind of delved into this world of regenerative medicine and orthopedic medicine, orthobiologic medicine. I am the immediate past president of the Interventional Orthobiologics Foundation, which really focuses on getting the injectee in the right spot by advanced training in ultrasound and fluoroscopy. I also teach for a number of other ultrasound-based training programs like OrthoSono and the MSK Forum and the Sonics, as well as having my own practice. I am in a rural environment, and I have moved my practice away from the common insurance-based care. I focus on a majority of cash pay procedures, whether it be orthobiologics or surgical intervention or marrying the two together. I really like to focus on root cause and do things as minimally invasive and naturally as possible. And I am really passionate about helping doctors incorporate orthobiologics ultrasound in their practices successfully. So we'll move on. So are you looking to improve your patient outcomes? I think there's so many people that are looking for a way but don't know that next step. You find that your patients, have been told they need surgery or think they need surgery, but they don't. They maybe have gone to physical therapy, but there's still this nagging issue. And you're wondering, I wonder what the root cause is. I wonder what the diagnosis is. And so there's a lot of things that kind of fall in this gap between, where they've done the standard conservative therapies and maybe it's not getting the job done, but they're not a candidate for surgery, or they don't want surgery, or maybe they don't need surgery, but yet they're not good. And unfortunately, in my line of work, what we used to tell them is like, well, good news, you don't need surgery. Come back when it's worse. And that was it. And so really, that was really frustrating. These are really great opportunities to do a better job as a practitioner. And that is where orthobiologics and ultrasound come into play. Orthobiologics has been a game changer for me. I get great outcomes. Everyone has kind of been knows it has been popularized by the professional athletes, but now in the last 10 years, we've had a significant increase in research and data collection. We even have organizations focused strictly on orthobiologics, like the Biologics Association and the Interventional Orthobiologics Foundation. And we're really focusing on getting the right answer. You probably have also been aware of increasing patient demand. And let me tell you, it also helps with increasing your ability to have autonomy in your clinic. You don't have to rely on insurance companies to be able to have a healthy, robust clinic. So a little bit about autologous therapies, or platelet-rich plasma, cellular therapy, bone marrow concentrate. We know that these accelerate the healing process and decrease pain. We also know that these treatments can stimulate your patient's adult mesenchymal stem cells to affect repair. We know that they stimulate fibroblast growth, collagen production, and releasing those growth factors that are stored in the platelet alpha granules are involved in that tissue repair and regeneration. And here's what I hear all the time. Oh my gosh, I do not have another time to learn another skill. I can't afford to learn this skill. I don't know how to do ultrasound. I don't know how to do orthobiologics. And let me tell you, I think learning ultrasound and applying ultrasound in your practice is something that is going to be the vehicle, that catalyst for actually helping your practice become more robust. Let's face it, reimbursement is not going up. Yes, this year Medicare cut another 4%. This is not a good trend. And I'm pretty sure next year, they're not going to just give us that 4% back. So this is a way to really recession-proof, pandemic-proof, retirement-proof your practice. You get to enjoy your life more, have better outcomes. You have another tool in your tool belt. You can get off that hamster wheel, and ultrasound is what makes it possible. So why is ultrasound the game changer? So many reasons. So number one, you can get real-time diagnosis. You can, in real time, diagnose the patient that is sitting right in front of you. You can use it like a glorified flashlight. Does it hurt here? Does it hurt here? What about this part? Or, have the patient point to it. It hurts right here. And then put your ultrasound on and go, oh my gosh, that is not what I thought it was. Because as we know, patients are very variable and anatomy is quite variable. And so if you don't look, you don't know. And so the ultrasound allows us to look. right there and then. Then you can move the patient. You can see if it's stiff. You can see if that biceps is subluxing. You can see if your peroneal tendon is subluxing. You can see if your rotator cuff is gapping in real time. Now, when you're doing injection-based therapies, the ultrasound, in my opinion, is necessary and critical to place the injectate in the proper place. Without ultrasound, we just don't know exactly to the level that we need to where we're placing the injectate. I know there's a lot of patients, doctors and practitioners say, oh, I know where the joint is. I've been doing this for 20 years. But what we know is the science shows that it's not 100%. And with ultrasound, you can be very sure, 99%. I would prefer to have that number on my side. And then I'm going to share with you an experience that I had just recently. And I knew that ultrasound in my diagnostic acumen and in my consultation is a practice differentiator. But let me leave you with this story. We were doing a consultation for possible orthobiologics, and we have the luxury of just putting the ultrasound on an exam and saying, okay, let's take a look right now, and explain to the patient on the screen what they have, what they own. Just like you see me here with this gal in our teaching. You can point out that pathology in real time. They don't have to go get an MRI. They don't have to wait, and they can see it with their own eyes. And my patient said, that was one of the things that made me really sure I was in the right practice, is because I couldn't believe that you could just do an ultrasound right there and then and show me what the problem was right there and then create a treatment plan based on that right there and then. That saved me so much time, so much worry, and what should I do? What's the diagnosis? You told me what the diagnosis is. I saw it with my own eyes, and you told me what the problem was, how to solve the problem, and I can just move forward with my life. So really, it does allow you to differentiate your practice from the guy or gal next door. And then I do believe that we are leaving money on the table. Just like in a surgical practice where you see all of these patients because you're trying to sift through and sort through all the ones that need surgery, and then you're ignoring all the rest of them. When in reality, you can just serve all of your patients, not only the surgical or not only the non-surgical, but you can serve these patients that are in the gap using ultrasound and orthobiologics. So, how does ultrasound improve your practice? Like I said, we don't always know where the joint is. Blind injections are about 60 to 80% accurate. With ultrasound guidance, 99% accurate. And I'm sorry, I don't know about you guys, but I'm an A student and I want A work. So I'm not okay to settle for B- work, especially when people are trusting me to help them get better, and they're trusting me with their hard-earned money to get amazing outcomes. I am shooting for that 99% accuracy, and really to just guess is not acceptable. Like we said, they love to see it in real time, and it puts you in the driver's seat. And by the way, an extra $300,000 in my pocket last year for ultrasound-guided injection-based therapies. Yeah, I'll take that too. So you can't afford not to learn this. Please take the time to learn this. I'm going to share with you a little bit about this cash micro practice model that I've been talking about. And so people that I talk to, my colleagues and my friends, are like, gosh, it sounds like a great thing. I want to learn how to do ultrasound. I want to do orthobiologics. And how do I, it just seems like a lot. Am I going to have to quit my whole practice and scrap my whole practice? And what we've found is that you don't have to quit or scrap anything. What you can do is just create a little micro practice that is the infrastructure to allow you to accept cash payments and provide a cash-based service outside of the insurance-driven world. This then gives you a more efficient pathway that adds value not only for you, but for your patients. It allows autonomy, not only for you, but also for your patients, because they can choose. They don't have to wait for a referral. They don't have to wait for insurance to approve something. And it allows me to serve my existing patients better in this other alternative of how to serve my patients outside of the insurance-based world. So when we use ultrasound for an orthobiologics-based practice, I sometimes hear like, well, I mean, I don't even know what patients to use this on. Who, like, my patients aren't going to pay, which we all know that's not true, or we will know that's not true. But also, like, who do I use this on? Yeah, you've said it's going to change your mind practice, but who do I use these people on? And so one of my favorite things to do is say, okay, these are the patients that you see in your practice. And so these are my top 5 diagnoses that have really been a game changer for me to be able to offer these therapies for my patients. Number 1 is lateral epicondylitis. It probably has the best and most robust data for efficacy of platelet-rich plasma injections for lateral epicondylitis. We also know that it's pretty recalcitrant to standard physical therapy, conservative therapies, and it seems to recur. And we also know that it's rarely required for surgery. And so lots of people just kind of put up with it and live through it, and they have these flare-ups, and then they quiet down, and maybe they'll use the brace for a little bit, and then it quiets down. But when we get to the root cause of why this happens, this is a tendinopathy. These are partial tendon tears. These are things that have been put at risk because of the regression of the blood supply, and it is not allowing the body to affect its natural healing process because it doesn't have robust blood supply. So when we use platelet-rich plasma for these applications, we then are reinstituting that blood supply. We know that orthobiologics, and specifically platelet-rich plasma, helps to cause what we call neoangiogenesis, which is where we get more blood supply where we place the platelet-rich plasma to bring the body's natural healing response to the site of injury to actually finally solve the problem. The next one we talk about is these partial thickness rotator cuff tears. We're all kind of working on and for the same root cause. You have this regression of blood supply in that supraspinatus. Supraspinatus partial thickness tears are ubiquitous. They're everywhere. And some are symptomatic and some are not. And while we wouldn't say, oh gosh, like, let's hurry up and go to surgery, sometimes physical therapy can't get the job done. And this is where that orthobiologics and ultrasound-guided injections are a game changer. When I do shoulder injection-based therapy, I'm also adding ultrasound-guided nerve blocks to all of my patients' treatments. And that, for me, has really changed my patient satisfaction because they really are able to have a pain-free experience. Again, another differentiator for your practice is to have this pain-free experience where they get to see the thing happen in real time, and they're doing all these cool cutting-edge treatments and ultrasound-guided this and that. And they don't have to have surgery, and they have very limited downtime, just a couple of days, no real restrictions from an activity standpoint, and then their body just starts that healing process. And by 8 weeks, we get at least 50% improvement, and it's the whole natural progression. The other options, so for my top 5 diagnoses, we'll run through them. Gluteus medius partial tendon tears, knee arthritis is a top performer. And my favorites is MCL strain, because MCL strains, they kind of nag at you, and, you strain your MCL, you think it's going to get better. Everyone tells you it's going to get better. And then 3 months down the road, it's still not better. And you're like, man, every time I get in and out of the car, every time I go try to like change directions, every time my dog hits my foot and it, stresses it, you're like, oh my gosh, this is killing me. So, for a very, very minimally invasive, simple process under ultrasound guidance, we can actually completely sort that out. And they respond really well to this treatment. So I did want to share just a little picture of this partial thickness rotator cuff tear. This is under ultrasound guidance, and this is this greater tuberosity here with the rotator cuff, a little partial thickness tear with some tendinopathy. And what you can see in real time, and what your patient can see in real time, is that the needle is coming directly into the tendon, but because we've done a nerve block, it's not hurting, it's not, it's not scary. And they get to watch this entire treatment under direct visualization. And where that injectate goes very, very specifically. And you can correlate in real time what the location is. And the other thing that we know is sometimes these rotator cuff partial tendon tears are more significant once we get in and we be able to inject fluid into the tendon. It then elucidates that it was a much more significant tear because it's delaminating. And we see this in real time on ultrasound, and you cannot see that delamination in MRI. And you can't actually see that delamination even in surgical intervention. You don't have the opportunity to appreciate that. So I think from diagnostic and therapeutic purposes, ultrasound, it blows everybody away from that perspective. So as we know, this is an MRI of a normal hip, and this gluteus medius, everyone wants to blame the piriformis, and that poor muscle gets blamed all the time. But the gluteus medius is what we would call the rotator cuff of the hip. And it has the same thing. Everyone else calls it, oh, my hip bursitis. Well, in looking at MRIs of all of my patients with hip bursitis, number one, it's not a bursa. And number two, 9 times out of 10, it's a gluteus medius tear or a partial tendon tear. So it's not bursitis. And so to treat a partial tendon tear as bursitis would be doing the patient a disservice, because a lot of times practitioners treat bursitis with cortisone. What we know is when we apply cortisone injections to tendons, it weakens them. So from just a logical standpoint, if we already have a weakened tendon and we inject a blind injection of cortisone into the gluteus medius tendon, number one, it's not going to help it heal. Number two, it's going to weaken it. And unfortunately, number three, and I've seen this more than one time in my practice, it can cause rupture of the gluteus medius tendon with significantly worse function going forward. So for me, the gluteus medius, platelet-rich plasma injections under ultrasound guidance has been a game changer for my patients. These things are annoying regardless of type of treatment, whether you're doing physical therapy, whether you're doing shockwave, whether you're doing platelet-rich plasma, whether you're doing surgery. These take a long time, and so you do have to counsel your patient. It's going to take a while. I don't really have a good answer as to why it takes so long. Number one, I think it's hard to offload it, to give it that relative rest. Number two, I think that there may be some tie-in with some low-level or subclinical radiculopathy that we're not picking up as well. So I do have this MRI, that partial gluteus medius tendinopathy of the gluteus minimus and partial tendon tear of the gluteus medius. So the anterior facet is that gluteus minimus tendon, and the lateral facet is the gluteus medius. It is a really nice opportunity to be able to see these on the ultrasound really, really clearly. It takes 2 seconds, and you can then, number one, diagnosis with a stress, ultrasound, or you can do a fluid challenge, or you can do what we call diagnostic and therapeutic injections with just lidocaine, just to turn off that area where we think the problem's coming from. And then that gives them that perspective, like, oh my gosh, if I get this injection of platelet-rich plasma, it's going to recreate what I'm feeling now. So we use diagnostic and therapeutic injections a lot to kind of recreate or predict how people are going to be responding to our injection-based therapies. So I hope this has given you a little food for thought. And I just wanted to tell you, whatever you do, I do think that you can add ultrasound guidance and orthobiologics to your practice. There's a lot of YouTube videos. There's a lot of things, but you can do it yourself, or you can learn from an expert, right? All you need is to just pick up your ultrasound, kind of feel your way around. But what I've observed in teaching and training and learning myself is, if you don't know what you're looking for and you don't understand the basic underlying principles, it feels like you're looking at a polar bear in a snowstorm, and everything's white and fuzzy and you don't really understand. So I would learn from an expert who has a tried and true system to be able to get that done, whether it's AMSKU or another system that helps really solidify the principles of how and really walks you step by step through, and then holds your hand every step of the way. So you're like, is this right? Yeah, this is right. This is, oh, okay, good. Okay, next step. So please don't waste your time, energy, money on things that don't work. Choose something, learn from the experts. And then the final thing is, I do want to share with you an opportunity and some exciting things. I have been putting this all together for my colleagues who are like, how do I do this? And what we've done is we put an orthobiologics masterclass together, talking about clinical foundations, everything you ever needed to know about PRP, even if you've never done one thing. And we, let's see here. We also have how to find your perfect patient, how to create your micro practice infrastructure, how to find those patients, how to talk to those patients, how to do the consultation so patients say yes. And we also include a tiny little quick start guide, musculoskeletal ultrasound quick start guide. And Ryan and Colin have been so gracious enough. They also have allowed me to include in this the beautifully put together atlas on how to check if you're doing it right. So just wanted to share, this is the comprehensive program is 5,000. Apex Biologics has been a company that I've been working for, and they have really helped to elevate this, and they are subsidizing. So it looks like the QR code kind of cut off on my slide, so I'll get that to you guys if that's something that you're interested in. We also do weekly calls and monthly in-person deep dive workshops for that masterclass in Clearwater, Florida. So I just wanted to give that, but no matter what you do, it is time to take action. Make sure you integrate ultrasound and PRP in your clinic today. Don't just dabble. Let's work together to get a world-class orthobiologic and ultrasound experience for your patient. Your experience will pay for itself. So don't forget, I have a podcast that kind of walks you through if you're interested. Anywhere you subscribe, it's The Business of Orthobiologics. And then I just wanted to thank you for your attention, and we'll go to the back to you guys.
Well, I just want to say, very impressed with your presentation. Every time we hear you speak, we always learn new things. Hey, everybody, on this website here, you'll see a little smiley face that has interactions. Everybody give her a round of applause. She did a great job here. Always learning, always excited. We love working with you. We always enjoy everything that you do in collaboration with us. And we're here to support you as much as anything. So let me go ahead and share something here real quick. So as everybody knows, this is now the time for Q&A. There's a Q&A tab that we have on here. If you all have questions for Ariana with some of the stuff that she's brought up, if you have any questions for Colin and myself, this is a great time to be interactive. That's why we're here. I think it's a great time to sit around and listen to people talk, but this is now, we've presented this in a way to where we want to have open forum, and we want people to, bring up the questions that are burning in the back of your mind, because if it's in your mind, chances are it's in somebody else's mind too. So we have the Q&A open right now. I will leave that open here, right here. Looks like some things are coming in right through here. Let me see. Well, before I go into the Q&A, just so everybody's aware, as Ariana said, we have partnered together. We are using some of our information with her program. So we do have a residency program as well. So if that's something that anybody's interested in, I would highly, highly recommend getting on a discovery call with Colin and myself. At least learn from our perspective. Don't just take it from a slide that you see here of what we offer. Get deep into the questions and call us. So we have a discovery call. We're going to be posting the link to the discovery calls that you can call us. We'll take those. And here's the cool thing is even if you just book a call with us, we're going to give you a free intro course, so off of our website, we'll just give you that full course just for signing up on a discovery call to learn a little bit more about this. All right. So now that we've done this, let's go. I'm going to stop all the sharing, so you guys are going to see all of our faces here. So we have some questions here. Let's see. First question I have right here. This, could you walk through the process choosing the correct nerve block based on the pathology you are treating? Is this targeted nerve distribution into the respective treatment areas, or are there other factors that inform your decision-making? Obviously, this is going to Ariana.
Yeah, absolutely. Okay, so I usually, as an example, so I use for shoulder-based injection-based therapies, I have a couple of options. I can use an interscalene block, or I can use a suprascapular nerve block. A lot of times people have been taught how to do suprascapular nerve blocks based on the sphenoglenoid notch posteriorly, because that's easy to identify there. But unfortunately, it doesn't catch some of the earlier takeoffs to the supraspinatus or subscapularis. So there's some other ways to get to that, either looking directly down through the supraspinatus fossa, or a little bit of a different approach is coming just medial to your coracoid, where you have that suprascapular notch as well, and doing an out of plane injection there. How do I decide, though, is a great question. So number one, if they drove themselves, they cannot have an interscalene block. If they are getting bilateral, then I will do one interscalene block on the more involved side, and I'll do one suprascapular, because you don't want two arms that don't do anything, right? Like how do you go to the bathroom? Like pull up your pants, whatever. So I try not to do two interscalene blocks, and there is a risk of knocking out the phrenic nerve on an interscaling block. So doing bilateral interscalings would be way more risky than a single-sided interscaling block. So I try to decide how much discomfort they're going to have, and then what function, if any, I want from them in the early post-injectate phase, versus, do I want to buy them a lot of time to have be free from pain, because I know it's going to be super uncomfortable for about 48 to 72 hours, and I want them to get home, get some food in their belly, take a pain pill before it wears off? Or do I want to make sure, if I'm doing like nerve-based treatments, do I want it to be fast acting so that when it's just covering the time when I'm doing the injection, and by the time they're leaving my office, it's worn off and I can check motor function? So I hope that helps a little bit.
That was great. The questions are pouring in. Let's start moving on with these here a little bit. So we have Cynthia asking, "Hi, what is a good evidence-based study about PRP injections?" Wow, I think we've all been in enough of these courses, and we've all done our own research on this. Obviously, I'm going to lead this towards Ariana, but there is plenty of data out there. So, Ariana, is there anything that you would point toward this one?
That's a great question, because I think that is one of the hurdles, is how do you kind of gather in your brain all of the studies that support what you're doing, right? Or like, okay, yeah, that makes sense. This is something that we call it in my clinic, is it PRP-able? Is this diagnosis PRP-able? And we make that decision based on the literature. So I think that's such a good thing. So in my course, what I have done is kind of amassed all of my favorites on. There is actually a really good resource. If you go on the Apex Biologics, and I'll put that in the chat, how you spell it. The Apex Biologics site, there's about 60 to 70 papers on their resources tab, and that you can click on and read, and that gives us a really good resource start as to like where to go. What I do know, and this is kind of an aside, but people always tell me, oh, that there's no evidence for that. But what we do know is there's about 144 randomized controlled trials regarding platelet-rich plasma. So there is very high-level studies that have been done. And when you look at the majority of them, the majority are in the positive, meaning that there is efficacy for the use and consideration of platelet-rich plasma. So let me put that in the chat, and maybe I'll just get the website or from somewhere, and we'll figure this out for you guys.
So to kind of dovetail on that same question, we have Sharish asking a question. So is there a journal available? Like, is there a dedicated journal available to orthobiologics at this point?
Yeah. There is, and I think you're gonna have one of the editors in chief on maybe next month. I think it's just like orthopedic biologics, orthopedics, something like that. I can't remember I forget which one comes first. But there is a dedicated journal to this. I wish there was like 500. There are not, because it is my passion. And so, because this is a newish field, like it's still in its beginnings. It's in its infancy still. And so there's currently tremendous growth, and with growth comes responsibility. So let me find those things for you, and I'll get that in the chat for you guys.
Hey, everybody on this call, you guys are getting some real pearls here. You're going to get a lot of information that you're not going to get anywhere else. And yes, Ariana, thanks for sneaking in that little Easter egg in there, and we'll talk about that here in a second about who our next guest might be. So the next question that we have here is, what are the protocols you follow for post PRP for patellar tendon and tennis elbow? So this is going to be a very interesting question. So what are those protocols that you're following?
That's another hurdle that we recognize, and hopefully we'll have a solution for that shortly. But I think a good rule of thumb is that I've used, and it's pretty reproducible, is using those post-surgical protocols, those rehab protocols, and starting at week 6. So that's after that protection phase. And so, you can that's kind of across the board. If you can look at okay, this is like that surgery where they reattach the tendon, or this is like a rotator cuff repair surgery, but it was orthobiologic injections for partial tendon tears. You can use that on any surgical postoperative protocol and just start at week 6.
Well, only if somebody was going to work on this, right?
Wouldn't that be awesome? If somebody had a go-to resource guide for post-PRP protocols. All right, so moving forward, we have a good question from Brett Sandy here. Do you combo BMAC, so bone marrow aspirate concentrate, and PRP? And if so, where do you see the most success with that?
Yeah, so I don't combo PRP with BMAC, because when you draw bone marrow aspirate, you have a peripheral blood content. And so when I'm processing in my lab, I have bone marrow aspirate concentrate, and I have platelet-rich plasma to play around with. But if I'm going to be using bone marrow concentrate, I'm using that for more severe disease, more severe arthritis, more severe high-grade partial tendon tears or ligament tears. And so I wouldn't combo them together. And so, what areas do you see the most success? The body. Just kidding. No, it's phenomenal. I think there are some places that underperform. The hip seems to underperform. The intra-articular space of the hip seems to underperform. I think the tendinopathy, specifically the sheath tendons such as the patellar tendon and the Achilles tendon, as well as biceps tendon, those guys are a little bit more problematic than and I don't know why. What I do know is there's some really good research as to what happens in tendon biology with stress and stress recovery. And it has to do with timing and load and all of these things. So what I tell my patients is for tendon problems, specifically tendinopathy problems, this is a persnickety cell, right? These tendons are kind of annoying because they want heavy load, but not all the time. And they don't really want to rest, but they do want to rest, but just enough, but not too much. And they don't want inflammation, but they want blood supply. But it's an annoying situation. But given the proper dosage of injectate, rehab protocol, and time, these things are really good. And orthobiologic injections are really good. Are they the end-all be-all? No. Do I tell them that they're going to be 100% cured? No. What we do know, and some of the premier research done by James Fitzpatrick on gluteus medius tendon tears, is that those grade 2, grade 3 tendon tears treated with a single shot of platelet-rich plasma, leukocyte-rich platelet-rich plasma, Not only did they have about a 75, it was a little bit higher than greater than 80% improvement rate, and that persisted to 2 years. She did a follow-up study that was looking at MRI, and at 5 years they did MRI follow-up, and they had at least 50% of the patients who had a completely healed tendon. Completely healed. So for me, that's like, okay, not only is this awesome, but this is a disease modifying treatment that can now consider whether, you can use this and say, okay, well then, if I'm going to do a gluteus medius tendon injection using leukocyte-rich, platelet-rich plasma at the appropriate dosage and appropriate rehab protocol, I know not only am I going to get a very high rate of improvement, even at the 2-year mark, but I also have a 50% chance of complete healing. Okay, what's next?
Sold. And again, maybe I'm a little biased on this one, but I think the right place to do it also includes having the right diagnosis from the beginning. So, I got a couple more questions. We're coming up on an hour here. I just want to say to everybody who's stuck around with us, everybody's coming here from all over the world, it looks like. So we have people from all over the world. I want to say thank you for all of that. Thanks for sticking around. So another question, we have Alex Edwards. Hey, Alex, how you doing? Med student here. Was MSK ultrasound part of your curriculum, or was it something you picked up later in practice?
Yeah, ultrasound was definitely not in my curriculum. It was not in my med school curriculum. It was not in my residency curriculum. It was not in my fellowship in sports medicine curriculum. And so I had the luxury of taking that orthosono course in 2010, which was a while ago. And that for me was a game changer. That opened up my entire world as to how I went about my daily business. It helped with my diagnoses. It helped with ultrasound-guided injections. And honestly, I cannot imagine doing an examination without having the ability to look with my ultrasound. And there's no way that I would be able to feel confident and comfortable to do blind injections. I used to do blind injections. That's how I was trained. But then to now know what I know, there's no way I would do blind injections. That's like literally shooting in the dark. So it was not in my residency at all. And I did seek out additional training. And then about 6 years ago, I kind of went both feet into the orthobiologic world and got a whole heck of a lot more training with the Interventional Orthobiologics Foundation, which is it's an intermediate and advanced level, fellowship level training in needlecraft, in how to get the injectate to the right spot using ultrasound and fluoroscopy. And so I put countless hours, and then every time I teach, I learn like 100 more things as well. Oh, and YouTube is great, by the way. Half of it is on YouTube.
Is scary good. Yeah, and YouTube is scary good sometimes. So, okay.
The nerve blocks, the one I use all the time is Nysora.
Nysora. Yeah, they have actually really good videos for those nerve blocks. Okay, so I'm gonna hit one more question in here. So this is coming from Ryan Kuhn. Ryan, how are you doing tonight? Where do you find the limits of ultrasound in procedures? So when do you find yourself going towards fluoroscopy? Are you using ultrasound guidance for cervical facet injections? And how about utilizing dual imaging techniques? So are you using, a combination at some points in time? So you had mentioned fluoroscopy just a minute ago. So I think this is a good time to kind of answer that question.
Absolutely. So I think ultrasound does have its limitations. And so you can't have a comprehensive evaluation of the intra-articular cartilage health of a shoulder or a hip because you can't see through bone. So there are some limitations. It's not perfect. No imaging modality is. And so sometimes you're exactly right. You have to stack your modalities. An example of that is for my lumbar injections. I do a majority of my facet work under fluoroscopy. I don't do cervical injections currently, and so I don't. But I do know that a majority of my colleagues do both ultrasound guided and fluoroscopic confirmation for these treatments. And I currently have been disappointed enough in my accuracy with ultrasound only for the hip that I confirm with fluoroscopy because I have it in my clinic. If I didn't have it in my clinic, would I still feel confident? Yeah, but I would be more strict on the other tactile feel kind of things, and flow pattern confirmation and those kinds of things to be able to feel more confident. So I use every tool in my toolbox to figure out how to best treat my patient. I get MRIs, I use ultrasound, I use fluoroscopy, I use X-ray, I use physical exam, I use history, provocative testing, and diagnostic and therapeutic injections. Yes to all of them.
Absolutely. And even in our clinics, we have the mini C-arms and full C-arms, but we have ultrasound, and our practitioners, they use what they need to use. Ultrasound's not the end all be all, and there's going to be times where you need something else, right? So we have a couple comments in here, mostly just about protocols and things like that. I think we hit those up pretty good. We got 4 minutes until the end of the hour. I think now is just, again, a really good time. So like I said, for those who stuck around, give Ariana a big hand, a big round of applause here. She just crushes it every time that she comes on here. I'm going to share my one screen one more time, just so when everybody sees, there's the residency call. So if you have any questions, and I think it's important to note that this is not webinar number one. This was a hit. This was a great webinar, but we do have 3 previous webinars. So if anybody wants the 3 previous webinars that what we did, please reach out to us. We've done one on introduction. I did one on physics and optimization, and then we did one on return on investment. Why wouldn't you want to learn how to make your money back? I mean, to me, that's a no-brainer, right? So if you want any of those resources, come see us, come find us. We're putting all the links that Ariana talked about from Apex, from her stuff, everything that she has going on, we're putting in the links. We're going to email those to you. We're going to make sure that everybody on here has the right resources to get started. And here's the thing. Is if you book our discovery call and you get an introductory class and you're just an introductory course on MSK Ultrasound and you're kind of on the fence and you don't know what's going on, what better resource to kind of tip the scales to say, all right, this is something that I'm really interested in. And I mean, it's a huge value to anybody that wants to get that intro course. We're going to be continuing these, and I think Ariana had mentioned this briefly. I'm going to give you a little teaser here. Thanks for sticking around. For those who stuck around, we're going to have Don Buford, orthopedic surgeon and orthobiologic master as well. He's in the same caliber as Ariana here. We're all trying to work together for the same thing, is trying to get you all better. We're trying to help make healthcare smarter, right? And the smarter we are, the better our patients are. So any final words, Colin, Rigney, Ariana?
No, this is great.
It's just so fun. Thanks, Scott.
Yeah, these are always a blast, and I think we should do a roundtable, one of these webinars down the road, where we have a lot of the thought leaders together, and we can do a roundtable with that. So for the people that stuck around, I just want to give a huge shout out to Tariro. Tariro is our assistant. She helps put all of these together. I never want to forget how much effort. She's in Botswana. She's in Africa. So the time over there, I can't imagine, is conducive to anyone's sleep patterns. So Tariro, if anybody's there, please give her a round of applause as well. We appreciate everything that she does. Ariana, excellent webinar tonight. Looking forward to collaborating with you more. Colin, thank you for the introductions tonight. You're always on point. So I am going to be signing us off. Thank you, everybody, for coming in tonight.
Everyone. Thanks, Ariana.